Abtin Maghsoodi is the lead data scientist and National Data Science Community of Practice Lead at Health New Zealand Te Whatuora. He also serves as a Senior Research Fellow in Health Artificial Intelligence at the Division of Health Engineering, Computing and Science, University of Waikato. His research is applied work focused on leveraging artificial intelligence, soft computing, data mining, and statistical techniques. Rocking up to be quite an important presentation, as they all are. It's called REACH, Recognising Episodes of Acute Complexity in Health, a Predictive Older Patient Prioritisation Machine Learning Model.
Hi, everyone. Tēnā koutou katoa. Thank you very much for the introduction. So today I'm going to talk about an application of artificial intelligence and machine learning in patient prioritization and pathway allocation for older adults. My presentation is, to be honest, very similar to last year, but with some extensions to the previous model that we've created. This project is very close to my heart, and initially was part of my PhD project and a collaboration between Auckland University, Health New Zealand, and Waikato University. Last year in my presentation at interRAI Forum, I've presented the first part of this algorithm, which was previously called the traffic light system. And since we have expanded on the concepts within the model, we've changed its name to REACH, which is recognizing episodes of acute complexity in health. Though I have to say kudos to Matthew Parsons for coming up with this acronym. So yeah, I'll be very briefly go through some introduction and some stuff from last year, and then introduce the new model. Next slide, please. So we're getting old, and this is definitely one of the main themes of the forum. And there has been a wide range of opinions about different aspects of health and healthcare systems and trends in disability and chronic medical conditions. Also, despite the increase in life expectancy, deterioration and health complexities are just inevitable. This is one of the main reasons that geriatric care and management frameworks have been developed and expanded with an ultimate aim of care for older patients in order to meet their long-term care needs along with their quality of life. And for the same reason, Ministry of Health has released the New Zealand's Healthy Aging Strategy. Next slide, please. But that's not it. While we're talking about increase in life expectancy and patient complexities, we're also talking about increasing demand on our healthcare system. Therefore, improving the patient flow and establishing patient flow management within the hospital should become a policy priority to effectively set balance to the mismatch between the unknown and variable amount of supply and demand, considering our limited resources. But the question is, can the current system, the business as usual procedures, result in an ideal outcome for all inputs? It's actually a tricky question because in order to answer that, we have to consider various different metrics and measures. Now, one of the primary questions in order to control the patient flow due to limitation is resources is how to assign patients to appropriate pathways. And in order to answer that, we basically need to see what does an optimal placement for geriatrics look like, and how we can sort of automate this by minimizing resource use. Next slide, please. So on the other hand, according to the literature, one of the responses to acute older patient care was the ACE initiative, originally created based on geriatric evaluation and management framework. While they have their differences, they all have these initiatives are more or less focused on patient-centered care, early rehabilitation, discharge planning, prepared environment, frequent medical review, and multidisciplinary team intervention. We do have very similar setting in Health New Zealand as well, with Canterbury, which is called CREST, and Waikato District, which is called STAR. And next slide, please. And at the same time, data-driven modeling potentials have been recognized in geriatric care, where it addresses challenges such as caregiver shortages, resource disparities, and optimizing the allocation of healthcare professionals and resources, which is one of the main focus of this research. And there is a narrow body of literature focusing on geriatric care and predictive modeling using machine learning and AI models. On that note, can you please go to the next slide? There is a huge gap within the literature when it comes to developing and applying AI-driven model considering this population, especially when it comes to clinical and operational aspects at the same time for older patients. This study can be one of the first that created an AI-driven triage and patient prioritization model for geriatric patients, considering factors from geriatric-specific models such as ACE initiatives. So next slide, please. So in order to address the gaps within the literature, we sort of asked a question here. What is the optimal design of patient flow and how we can assign patients to appropriate pathways? So we need to basically answer a couple of essential questions in order to answer this primary question. And for that sake, can you go to the next slide, please? We created this framework to answer those questions. So I'm not going through the first phase because it was part of the preliminary sort of discussion for Reach 1.0, which was the previous model. But what we did is we've sort of a systematic review and meta-analysis was conducted in order to identify the components of geriatric care models and evaluating their effectiveness for the whole patient journey. I can share the paper that was published from this phase with everyone. And for the second research question in the first phase, again, the paper has been published. I'll share that as well. Our main purpose was to basically contextualize our findings from the first question to basically New Zealand population and validate the components with senior health professionals. So our sort of main objective there was basically to create a machine learning tool which we could sort of assign patients to complex and non-complex pathways, which was Reach 1.0 or phase 2 and third research question. Can you go to the next slide, please? So the second phase, the third phase actually, Reach 2.0 is following the previous sort of model, which we called the traffic light system model, in which now we are sort of trying to extend our machine learning model with a mixture of expert networks architecture using an ensemble of machine learning techniques in order to create the same sort of predictive model, not just assigning patients to complex, non-complex pathways, but also to basically be able to predict which patient would go to ARC, which are early supported discharge, which patient would be sort of mortal patient, or we could sort of predict the mortality on those patients as well. Can you go to the next slide, please? So I'm talking about Reach algorithm, the first one. The primary purpose, as I mentioned, was to create a decision support system and a triage tool at the point of the emergency department. So we used historical data to basically train our algorithm to basically see which patient have to go to complex, non-complex pathway. We trained the model based on more than 600,000 patient episodes for more than 200,000 patients from 2017 to 2022. And in order to make the model as optimal as possible, we have also considered a simulated bed occupancy within the machine learning pipeline to create a real-time system based on the bed availabilities. Next slide, please. So these are some of the variables that we sort of used in Reach 1.0. You can see that there are some demographic, operational, disease-related, and interRAI metrics in there. I have to note that we've created multiple versions of this Reach algorithm, from one that only have like interRAI assessment data, and we know that we might have like lots of missing data for other patients that hasn't done any sort of interRAI assessment. So that is why we created different models, and this is how the sort of optimal model looks like. Next slide, please. So we used an automated machine learning or auto ML model in order to do the model training for Reach, using a palette of model from regression to decision trees to gradient boosting, XGBoost, etc., etc. For the model selection phase, we ran the algorithm for a simulated timeline of 1 year based on actual and simulated occupancies, and then selected the base model based on their optimal performance. And next slide, please. So basically, this is how the outcome of the model looks like, the initial outcome. There are predefined thresholds that was extracted based on training data to define the complexity groups based on the probabilities, complexities, and patients are assigned to those groups based on those complexity probabilities. Just an example, you can see like patient 5 is complex with PCCL4 and 3 comorbidities, whereas, for example, patient 14 considered as non-complex. The tricky bit was for yellow complexity groups. At this point of the development, we suggest clinicians to overview the outcome and decide as the main filter for that yellow group. And for the future work, we are planning to basically create a reinforcement learning algorithm to basically refeed the clinicians and expert comments into the algorithm to refine the threshold and make a clinician-centered sort of decision support tool. Next slide, please. We've also created this interactive dashboard to have an executive and high-level summary of data. So at the moment, we're trying to do UAT and trials on this in order to make sure all the boxes are ticked before getting it onto production. Next slide. So Reach 2.0, we sort of, previous one, please. Can you go back? Oh, yeah. Perfect. So again, the primary purpose of Reach 2.0, similar to Reach 1, was to basically create that decision support system at the point of emergency department. This time, not just to predict complex and non-complex patients, but this time to basically predict complex, non-complex, early supported discharge, age residential care, and terminal patients. We trained the model based on more than 900,000 patient episodes for more than 700,000 patients from 2017 to 2025. And we've also, similar to the previous one, we've also considered occupancies there as well. And next slide. So this is how Reach 2.0 looks like. This is what we are currently working on right now. This is a work in progress. So you can see our optimal goal is to create some sort of a scale, some sort of a scoring system, which could easily act as a decision support tool and assign patients to the pathways that I mentioned. So for that, we are using a mixture of expert architecture, which I'll explain in a bit. But at the moment, we are creating this concept and we are sort of piloting this study, and we are getting appropriate approvals, including ethics, national AI governance from Health New Zealand, and a couple of more sort of approvals in order to be able to basically test our pilot and sort of deploy the model. So talking about the mixture of expert model, next slide, please. So remember how I mentioned the Reach 1 was working, like how we have like let's call it an expert which could have given us complexity probabilities for all the patients. And it could also give us binary predictions as well. So we have multiple experts here. One where it can give us probabilities for complex, non-complex. One where it can give us to say whether the patient should go into ARC or not. One for early supported discharge, and one for the mortality pathway. So we have a gating network which will help us to basically create that scaling system, that scoring system. If any patient has any sort of high probability of any of extracting from any of these local experts, it will go to the next gating network and to the next one, and it will tell us that whether that patient should go into that pathway or not. And we are connecting this network sort of architecture to a to our sort of resource use, to our bed occupancies, etc., to make sure it's working as optimal as possible. So next slide. Yep. I'm almost done. So we are currently trying to expand this model to create, and can you click on that image, please? Perfect. So we are trying to basically expand this model to create a real-time digital twin based on a simulated model and an actual patient flow in order to be able to create an optimal screening tool to analyze the allocation of older patients to the optimal pathways. So it wouldn't be just a decision support tool, but our plan is to basically monitor patients and see how they can move with the system. Last slide, please. So this research, this project would enable decision makers to make more informed choices around the development of patient pathways for older people. REACH can be an optimal screening tool to analyze the allocation of older patients to appropriate pathways. We are trying to make sure that we are building a model that could act as a decision support tool where it was created around clinicians' comments and viewpoints in New Zealand for our older patients in New Zealand. So that was me. Thank you very much.
Okay, thank you very much, Abtin. Do we have questions in the room? Yes. Kate, introduce yourself, Kate.
Hi, I'm Kate Walters, a visitor over from the UK. I had a question. I might have missed it, but I was interested in all the different variables that went into the model. Did you include social vulnerability, like a social vulnerability index kind of variables within the model, or they seem to be largely health derived?
Thank you very much for that question, Kate. That's actually very interesting. No, we haven't at this point. So, however, we are planning that for REACH 3.0, but that's something that we are still working on. But no, not on this one. So on this one, the majority of the measures are just health related or sort of operational related. So not at this point.
It just for information, it might be useful to link up with Jasmine Ma, who's a geriatrician working with Ken Rockwood in Dalhousie University. She's created a social vulnerability index using their routine data to go alongside the frailty index, and it does independently predict outcomes. So I'm sure she's got code she can share with you.
Thank you very much for that. I'll be more than interested to basically contact her and connect. We'll definitely do. Thank you.